This is Talking Heads. Explore the latest in research and policy about serious mental health disorders with Dr. Noosha Niv.
Hi, this is Dr. Noosha Niv, and today's guest is Dr. Stephen Marder. Dr. Marder is professor of the Semel Institute of Neuroscience and Human Behavior at UCLA, director of the section on psychosis at the UCLA Neuropsychiatric Institute. He's also the director of the VA Vision 22 Mental Illness Research Education and Clinical Center, which focuses on improving functional outcomes in individuals with psychosis. His research focuses on the treatment of schizophrenia and the pharmacology of antipsychotic drugs. He has authored or co-authored more than 200 journal articles and chapters and has won a gazillion awards for his work. In short, he's a very busy man, and I'm really grateful that you're here. Welcome, Steve.
Glad to do this, Noosha.
Thanks. What led you to psychiatry, and more specifically, the focus on schizophrenia?
Well, I mean, in medical school, I got enchanted by psychiatry, and particularly the kind of attitudes of psychiatrists who seemed more humanistic than some of the other clinicians that I saw. Many schizophrenia researchers have a relative or someone who suffered from psychosis. That wasn't my story. My story was when I went to the NIMH after residency, I was assigned to a schizophrenia research unit, which was fine for me, and it sort of set off my career.
Well, we're lucky it did. What are the biggest ways you've seen treatment change over the course of your career?
A number of things happened. During the first decade at UCLA, I became aware that there were limitations to what drugs can do. Antipsychotic medications attenuate psychotic symptoms, but they really didn't help people recover and return to work or school. So those limitations got me focused on psychosocial treatments. And I was influenced by a recently deceased colleague, Bob Liberman, at UCLA. And he persuaded me to become involved in studies that included antipsychotic medications as well as psychosocial treatments. I also spent a number of years going to state hospitals as a consultant, particularly Tascadero State Hospital, which is a hospital for the criminally insane. There I also realized that there were many patients who had really sad histories because they had illnesses that didn't respond well to antipsychotic medications. And I also saw that in my work as an inpatient psychiatrist at the VA in West Los Angeles. Then when Clozapine was introduced and I treated my first patient with Clozapine, I saw what was something remarkable, which was that a young woman who was 34 years old, tormented by a psychotic illness, suddenly improved and suddenly got better and was able to return to her goals from a decade before. Interestingly enough, after graduating from UCLA, getting her master's, she just retired after a career as a teacher in the Los Angeles school system. That showed me that the right treatment for patients can really change lives. It made me much more optimistic. When I visit with her, both of us so appreciate the fact that our lives were influenced by the other. Sadly, something that happened around 1989 or 1990 was the sort of last major advance in pharmacotherapy. There's a generation of newer antipsychotics, but they weren't game changers like the introduction of Clozapine. But what's happened over the years has been the development of better psychosocial treatments and improved rehabilitation, which made me optimistic about the ability of people to recover, and also substantial advances in the treatment of young people with schizophrenia, people during their first years of the illness, that front-loading treatments, aggressively treating them with psychosocial treatments and the right kind of pharmacotherapy can change the trajectory of the illness, that people who in the past would sort of move towards disability could change that trajectory and move towards recovery. And that made me, again, more optimistic about treatments for schizophrenia. And of course, the results from the large NIMH RAISE study show that could happen in very typical psychiatric settings if we have the right resources at the right time. So I would summarize those as the major advances during my time as somebody focused on the treatment of psychotic illnesses.
So the development and implementation of psychosocial treatments, and then treatment, establishment of treatment early on. So the earlier people get treatment, the better the outcomes. Right. And that we can change the trajectory away from disability towards recovery. You mentioned Clozapine. When is it appropriate to use Clozapine, and why is it so underused? Initially, Clozapine was a medication that was reserved for the most severely ill patients. What's happened recently is I think that we've begun to appreciate that Clozapine is also effective for people who are outpatients living in the community but still tormented by psychotic symptoms. So I consider it a medication that's appropriate for a large proportion of patients, much larger. I direct the psychosis clinic at UCLA, and there we have something around 40% of our patients on Clozapine, because we don't accept limited outcomes. If somebody, even if they're working and going to school, but they still have psychotic symptoms, we move towards Clozapine. So I think it's a medication for a much broader population of patients than it's currently utilized. To your other question about why it's so underutilized, that has tormented me for years. I considered one of my goals when Clozapine was first introduced as how to get psychiatrists more used to using it. And sadly, it's really challenging to do that. Prescribers will choose things that are easier to do than Clozapine. They'll add medications, they'll use high doses, they'll, add 2 or 3 antipsychotics, and it seldom makes a difference. And then Clozapine is like the last thing that they'll do. And many people are unfamiliar. It's the most difficult drug in psychiatry to prescribe because almost every patient has a substantial side effect burden. And the blood test is the least of the problem. It's the sedation and weight gain and other things. But when it works, it can really change lives in a substantial way. It's hard to get clinicians to use it, but I think, we're making some progress. I think as you look at some of the way the American Psychiatric Association, the VA, others are really convincing many clinicians to use Clozapine and to use it at an earlier stage of the illness, not to wait until a patient becomes hopelessly psychotic, where it's very difficult to get them out of that disability. Given the side effects, are patients resistant to using it, or are the benefits so good that they tolerate the side effects? It's a very mixed bag. For some patients, we'll tell you that they're better, but they're sleeping 14 hours a day, and it's really hard to get work done, and they have to make a difficult decision. That's for a minority of patients, and I think we need to respect that for some patients, it's not the right drug. But I think for others, they appreciate the fact that they could live in the community even with that substantial side effect burden. So how might a patient or family member advocate to receive it? Well, what I tell patients and families and loved ones is things in your life aren't going so well now. There's only one way to tell whether Clozapine is going to make a difference, and that's to try it for a few months. I think we need to convince patients that they're in charge of their lives and their treatment. And I think that one of my goals in treating people with schizophrenia is that patients take ownership of their illness. So it's not their family members and their psychiatrists and others who are telling them what they need to do. And for them, I really suggest that they make an informed decision and to make it based on an experience, and that a few weeks or months of side effects
an inconvenience is a small price to pay for being able to make an informed decision about whether or not this drug is good for them. It's sort of, give it a try. I don't think you have that much to lose.
And how do they convince a psychiatrist to put that time and effort in?
Well, that's where that could be more of a problem. But I do think that more psychiatrists are willing to give it a try. And some of them need help in doing that. Within the VA, we have a consulting service where we help psychiatrists learn how to use clozapine and sort of give them advice on how to address side effects. Some of the other challenges about administering clozapine in a way that patients are likely to accept it and where it's safest.
So psychiatrists might need other supports.
Right. That they'll need supports for prescribing it and, advice as things happen.
Okay. Going back to what you were saying about antipsychotics not assisting with recovery, can we talk about what symptoms antipsychotics actually help improve and why that's not impacting recovery?
To make it clear, antipsychotics don't lead to recovery, but there's a large literature suggests that they're an important platform on which to build recovery. It shows that patients who are on an antipsychotic drug and stabilized are more likely to benefit from psychosocial treatments and rehabilitation. So what I tell psychiatrists sometimes when I talk is that sometimes recovery begins once a patient is on an antipsychotic. And what they do is they attenuate psychotic symptoms like hallucinations and delusions and disturbed thought process and an inability to carry out a logical train of thought. What they also do is they prevent relapse. So if a patient has been stabilized in their psychotic illness where their symptoms are minimized, they're able to live in the community, perhaps to go to school or work, remaining on an antipsychotic makes it much less likely that they'll have a psychotic relapse, which in turn can lead to sort of a loss of some of the gains that people make and a loss of self-confidence that people have when they pull their life together, have a relapse, and then lose their job. Relationships can get destroyed. So it's important to emphasize how relapse prevention is really an important part of promoting recovery.
And do they affect negative and cognitive symptoms of schizophrenia?
If you look at it carefully, they have some effects on improving cognition and negative symptoms. And by negative symptoms, I mean the kind of apathy and disinterest in things that really torments both patients and family members. But they only do it to a minor degree. That is one of the challenges, to find other solutions to those problems in schizophrenia. The lack of motivation, as well as the cognitive disturbances. And for those, I think we need to look at this time to look at psychosocial treatments to those challenges.
So something like cognitive training.
Right. Cognitive rehabilitation, cognitive training can be very effective for both cognition and sometimes for negative symptoms as well, as well as cognitive behavior therapy.
You've been involved a lot in trying to at least develop medication to address the cognitive parts. Yeah. What's been the progress that you've seen?
There's been a number of studies of very promising drugs that sadly, they looked very promising in early stage studies. When they went to very large international studies, they failed. We still have a number of studies. There are a couple of very promising drugs that are in development for both cognition and negative symptoms. So I'm still optimistic that in the near future, we're going to have drugs that you can add to an antipsychotic that will be more effective for negative symptoms. There's also a couple of antipsychotics that are very close to FDA approval that act differently than all of the other antipsychotics. And those drugs also seem promising for cognition and negative symptoms. So it's likely, I believe, that during the next few years, we're going to see substantial advances in drug development. It's very exciting, but until it actually happens, I'll believe it. But I'm still optimistic.
So at this point, the reality is someone gets a diagnosis of schizophrenia. They are likely to be on a medication for a very long time, if not the entirety of their life. You've written a lot about side effects and that most patients don't like to be on these medications because of some of these side effects. What are the major ones you think people should be aware of and be watching for and talk to their psychiatrist about?
One of the problems is that antipsychotics attenuate psychosis. They don't make people feel better. So the things that I focus on the most are neurological side effects, a feeling of restlessness, or we call it akathisia, that patients may experience. Sometimes they cause stiffness, where patients, they don't feel as agile as they did. The other thing is metabolic side effects. Antipsychotics can increase the risk of developing diabetes, and they can also cause weight gain. That's not true of all antipsychotics, but it's true of some of them. And this is a substantial problem because people with schizophrenia, even before they get antipsychotics, are more likely to develop diabetes than people without schizophrenia, probably because of a shared genetic risk. And they're more likely to die sooner. The life expectancy for a person with schizophrenia is something like 20 years briefer than that for people without schizophrenia. And this is largely due to heart disease, antipsychotics and weight gain and, effects on lipids. All of those things add up to an increased risk. And of course, people with schizophrenia are somewhat more likely to smoke cigarettes, which also increases risk. So psychiatrists should talk to their patients about these risks. They should be more aware of the risk for weight gain. And together, we strongly recommend that psychiatrists and patients really watch their weight and that psychiatrists look for clinicians, I should say, because many patients aren't being treated by psychiatrists. They're being treated particularly by advanced practice nurses who really do a wonderful job. Watch their weight and to look for signs that have symptoms of prediabetes and to intervene, relatively quickly for that.
So what are some of the options to protect patients from these side effects?
The one thing that works very well is lifestyle changes. Every study that has looked at lifestyle interventions that include exercise and nutritional advice have shown to be highly effective. Those kinds of interventions are very effective. Other things that help, we often add a medication if patients are having these side effects. Metformin, which is a drug which could be used for prediabetes, but also helps patients lose weight, is something that we often prescribe. And there's this new generation of drugs that help people with weight loss. And they are highly effective for weight reduction and preventing diabetes or treating prediabetes. So I think we're at a stage where there are more options. And the other thing, of course, is to change the antipsychotic. If there are some antipsychotics, olanzapine, which is called Zyprexa, Clozapine, Seroquel, also called Clozapine, really are promote weight gain. But there are other antipsychotics where there's much less risk. So changing the antipsychotic can also help. So I think there are a number of interventions, but I think the first thing that I recommend to clinicians and patients is to look early on. What antipsychotics tend to do is there's a normal satiety response, a sense when we eat that we've had enough to eat. And it seems that antipsychotics sort of decrease that satiety response. So what we tell patients is, patients who've never had a weight problem who gain before they would stop eating when they've had enough, we emphasize portion control. things like that to help them not gain weight. And I think this is advice that we should give to patients all of the time because, again, this problem is so common in schizophrenia that we need to be aware of it right at the beginning of treatment.
Part of the stigma of schizophrenia is this kind of trope of the good patient, bad patient. You're the good patient if you take your medication and go to treatment as expected, and you're the bad, quote unquote, bad patient if you don't do those things. In that case, the attributions that family members may have is that you're responsible for your illness, you're responsible for the symptoms that you're experiencing. What would you say to someone, particularly a family member, who holds, an unfortunate perception of what schizophrenia is?
Well, I think one thing to do is to have them understand the problems that their loved one has, that being suspicious, being irritable is a symptom of an illness. Just understanding and empathizing with them. The other thing is that sometimes families get really annoyed at patients who have deterioration in their hygiene. They don't take care of themselves. They're late. They're more difficult. To understand that that's not something intentional. That's, again, part of their illness. That the cognitive disturbances, the things that we do easily, can suddenly become more difficult for them. That this is part of the illness, that blaming them is a problem. The other thing is that people with schizophrenia are sometimes much more sensitive to criticism than others. As I've talked to families that have a number of children, one of whom developed schizophrenia, they will talk about from a very early age, they realize that their son or daughter was more sensitive to criticism than the other, and to make them aware of this so that they're less blaming. So that's the kind of advice that we try to give to families. It's to empathize with them that this is very difficult to see this change in their son or daughter. It's just a very emotional response. It could be a sense of loss that they need to deal with.
Absolutely.
So these are very difficult conversations that we have all the time.
Okay. Yeah, there's a lot of grief in being a family member and grieving the person they had.
Right. And sometimes what I tell people is that, particularly early on in the illness, one, don't give up on your goals, because a lot of people can recover with proper treatment, but it may be longer, and it may be that it'll take them longer to get through college because they'll need to take fewer courses. And it may be that their career goals will change to things that they're more able to do. Sometimes families, once they accept that and support it, that they really help patients reach their goals with an understanding that their life will be, like anybody who has a chronic illness, whether it's diabetes or rheumatoid arthritis, or that there are challenges with having an illness, but it really doesn't define who that person is.
Mm-hmm. And at the core of that, being able to be empathic for family members is for them to understand these symptoms are of an illness, and not purposeful. They're not, it's not that they're trying to hurt family members.
It's not trying to hurt family members, right?
So can we talk about, patient shows up in your clinic for the first time. What can they expect? What happens?
Well, in our clinic, they'll be evaluated. We'll do a history. We'll find out what treatments they've had, because we're often a referral source from other clinicians who aren't as familiar with the illness. And then we'll sit down and we will give them an assessment. The thing that we always ask is we try to emphasize that we want to be behind the person's goals. That the goal isn't to be a remitted person with schizophrenia. The goal is, what are your personal goals? Well, what kind of life are you looking for?
So that could be work. It could, girlfriend or, okay.
Right. We define ourselves, and that the treatment is part of that. I think as mental health providers, we see treating their mental health as a road to help them reach their own personal goals. So we emphasize that, and that treatment is a part of that. We often emphasize for patients who are resistant to taking medications or getting psychosocial treatments, we try to emphasize that we're on their side because they've had people breathing down their neck, family members, other people. We try to sort of change that relationship. What we want is for the person to take ownership of their illness and to understand that once they can manage that, it becomes easier to reach their personal goals. So we're always sort of focused on their own, we can call it a recovery plan, or sort of helping them reach their personal goals. Mm-hmm. So I think we try to change the narrative of treatment away from just managing symptoms towards lifetime management. In our clinic, we often get the question, doctor, do I need to be on these medications for the rest of my life? And we address that question, very honestly, which is, who knows? We'll have to see. But we need to learn this together. In our clinic, and the way we work is we try to work together to understand the illness. And sometimes, Noosha, something very magical happens once a patient understands, when I reduce my medication or I stop taking it, actually things fall apart a little bit. That's when the person appreciates why they're getting treatment. If we involve them in cognitive behavior therapy for psychosis, they can see that they learn how to manage their symptoms, that it sort of gives them a feeling of having more control over their symptoms.
So they may need to experiment a little to really gain the appreciation.
Right. And it's not something, sometimes it's a long-term process. Mm-hmm. Sometimes if a person is drug reluctant, they're not taking it regularly, some psychiatrists will throw them out of the clinic, and we don't do that. We try to work with them to understand why they're not doing it and to sort of gain their trust. And as you could imagine, suspiciousness is often a core symptom of the illness, and how to sort of address suspiciousness is it's an art, Noosha. It really requires a particular kind of skill. Our clinic is a place where we train clinicians, and we try to get them to understand that.
What I'm hearing from your clinic is that you really partner with the people who come through your door, rather than I'm the doctor, I'm going to tell you what to do. And when you're suspicious, someone telling you what to do,
right,
doesn't work so well.
Right. And sometimes it's hard not to, because, when people are suspicious, they could be unpleasant.
Yes.
They could be very challenging. So maintaining your posture as an empathic clinician can be difficult. And I think that's part of the training, the kind
your
of
ego aside a little.
Right.
Is it helpful to you as a physician for a family member or close friend to come in with someone in those initial visits?
Yes. Yeah, absolutely. In contrast to other psychiatric disorders, the family can be the most important ally. Most studies have shown that patients who have supportive families do better, and they do substantially better. So getting the family as an ally is really vital, and letting them understand their role, and also having family members feel free to contact the clinicians as long as the patient understands that relationship is there, because, sometimes patients don't want that. But getting kind of a free flow of information, because sometimes family members are aware that somebody's getting worse or having a problem before the patient is. Being able to exchange that information without sort of offending confidentiality and having the patient understand can be very, very helpful.
So they, obviously your clinic will give them medication, but we've talked about the proliferation of psychosocial treatments. Which ones do you find are available to your patients? I mean, that's the real challenge, right? Is that these treatments are not widely available.
They are not widely available. In our clinic, we have psychology trainees and psychology supervisors, and we can provide treatments like cognitive behavior therapy for psychosis and cognitive remediation and other treatments. Social skills training. But in the community at large, it can be very hard to provide, to find a clinician. There are lots of people who are trained in CBT, but very few who are trained in CBT for psychosis. This is a major problem, and I'm hoping that the availability of remote treatment will make this more available. So, for example, in the VA now, we're able to deliver CBT for psychosis remotely. Cognitive remediation can be done through websites. Metacognitive training for people with delusions can be delivered through web-based treatments. So I agree that we have a mental health workforce that's really deficient in being able to provide these treatments. There just aren't enough trained providers. Right. That we have to find other ways to do it, and of course to train more clinicians.
And technology is really changing how we can.
Yeah, I think we have a number of new opportunities for providing these treatments.
Okay. I want to switch gears. In some Facebook groups, I had some patients ask questions, just patients, family members as well. Is that okay if we talk about those?
Sure.
All right. The first one is, what is the PANSS and how can consumers make sense of it?
Well, the PANSS is a research instrument. It's the positive and negative symptom scale. It's the most commonly used scale in drug trials. I don't think it's something for patients to be concerned about. As a matter of fact, most clinicians haven't been trained in the PANSS. Patients should understand what symptoms are and be able to describe them. But I don't think that the PANSS is the right way to do it. It's really not an instrument that patients need to become familiar with. On the other hand, learning to describe their experience, whether they're hallucinations or distortions, can be very, very helpful. It's one of the things that a good psychotherapist and a good clinician will do, is helping patients be able to describe their kind of internal experiences so that the psychiatrist can understand them and treat them.
So really for the general population, if they want to understand the PANSS, maybe they're reading a research article, higher scores mean higher symptoms.
Right. It's a way of, if they're reading the psychiatry literature, which is a little frightening, but you're right. A higher score means that they're worse, and it describes both positive symptoms like hallucinations and delusions, and studies may have negative symptoms and other kinds of groups of symptoms that may improve on an antipsychotic.
The next question I got is, I've read that BI 425809 is classified as a breakthrough treatment for cognitive impairment. How effective is it, and when will it be released? And I had to look this up, so correct me if I'm wrong. This is a drug called eclipirtin.
Yeah, eclipirtin. Yeah.
Okay.
Yeah, and we're actually studying it at UCLA. It's a drug that's being developed for improving cognition in schizophrenia. Mm-hmm. It was effective in early, in relatively large trials, phase 2 trials.
Okay.
And now they're in a large phase 3 study.
Okay.
The company feels very optimistic about it. So I think we're probably going to know relatively soon whether or not it gets through this phase 3 trial, in which case it may come to market. There's a process that could take a year or more once there's a positive phase 3 trial to get the drug to market internationally.
Is this an antipsychotic that also impacts cognition, or just the cognitive symptoms?
It's a drug that would be added to an antipsychotic.
Okay. And next question, and I know I'm going to say the name of this drug wrong. What is ulotaront?
Riliperidone. Yeah, that's a drug developed by a company in Italy or Israel. I forget, but it's a promising drug. It's being developed as a broad antipsychotic, which may have particular effectiveness for psychosis and negative symptoms. So it seems promising.
So it's different than existing ones in that it may...
Yeah, right. It's got a different mechanism of action.
Okay. Are there other medications currently under development for schizophrenia that you said you feel hopeful that in the next few years?
Well, yeah, there are. There's a drug that just passed through a phase 3 trial. It's a combination drug, but they had a positive phase 3 study, and that's from a press release. I haven't looked at the data yet, but it's made by a company called Karuna. It's a antipsychotic, which has an entirely new mechanism of action. And again, I think that's close to being submitted to FDA for approval. So that could be the first new drug. There's another drug that's called a TAR1 agonist that's made by Synovian, which has had very strong data from phase 2 trials. And again, it's a broad spectrum antipsychotic, entirely new mechanism. It looks very, very promising. We're optimistic that will come to market, but we're just waiting for the phase 3 study to see, whether or not that's been verified.
That's exciting times.
Yeah, it's very exciting. It's very exciting.
Another question. My friend told me to try transcranial magnetic stimulation. Does that help symptoms of schizophrenia?
That's unknown. There have been studies of transcranial magnetic stimulation. It's kind of something where you go into an office, they put something on your head and they do magnetic stimulation. There are some studies that show that it can be effective for voice hearing. It could decrease they apply it to the part of the brain that affects speech, and that it seems to decrease voice hearing. Those are very small, limited studies. There are other studies that suggest that it might be effective for negative symptoms. Again, those are very small studies. So it's promising, but I think it's too early to say.
And last question. If you had a magic wand and could change anything in the field of psychosis, what would you change?
It's hard to think of one thing, but I would want an antipsychotic drug as effective as Clozapine without the horrible side effects, that works through a different mechanism. I would want to rename the disorder so that people understand that people with schizophrenia vary as much as people with diabetes, from people who are highly functioning, accomplished people to those who have a horrible disease burden, to take away the stigma that's associated with that diagnosis. Thirdly, to just have a health system that makes these treatments, effective treatments, more highly available, that it's an illness that's greatly undertreated.
And we have the treatments that can improve outcomes.
We have the tools for patients to do much better.
Yes.
We just don't have a healthcare system that's able to deliver them.
And with that, we'll say thank you so much. I really, really appreciate you joining me today.
Okay.
This is Talking Heads.